Hello, everyone. Welcome. This is the July 22nd edition of the Decaturish.com Twitch show. I am your host, editor, and publisher, Dan Wisenhunt. We have a very interesting show for you today. Our featured guest is infectious diseases doctor and researcher Colleen Kelley at Emory University. Colleen, how are you?
I'm good, thanks. Thanks for having me.
Thank you for joining us. And as always, we have contributor Hans Utz. Hans, how are you?
I'm doing really well.
A-
Thanks, Dan.
And we have Decatur's contributor Crystal Jarvis. Crystal, how are you today?
Good. Thank you, Dan, for asking.
Thank you for being here again. It's always a pleasure to have all of you. I wanted to just let everyone know who's just tuning in. The way this works is if you want to ask Dr. Kelley a question, you're going to want to create a Twitch account and give us a follow because our chats are set to followers only now. So you can just create an account, give us a follow, jump into the chat, and ask us a question. And we're going to check in with you every 15 minutes or so to see what you have to say and what your comments are. So, Dr. Kelley, I understand that you were at Grady Hospital today, correct?
That's where I am.
So, what do things look like at Grady Hospital right now, from what you can see?
I mean, things have gotten really bad again. We are overloaded with COVID patients, similar, but actually a little bit worse than we were back in April. So, we have seen this kind of surge that we've seen in our testing data that we've all been watching here in the state go, rocket up, is now, feeling in the hospitalizations as well. So it's exhausting. It's constant. And so, that's the reality.
What do you attribute to, there's a political debate that's still going on about what caused the uptick in cases. What do you attribute that to? What is your thought on
I
it?
mean, we just relaxed. We relaxed restrictions too quickly, and we relaxed the wrong restrictions. So I think, back in March when things were relaxed, we should have been thinking about relaxing the things that we knew were safer, as opposed to those things that we knew were dangerous. So, outdoor activities and things like that. Those are the things that should have been relaxed. But the indoor activities and dining and bars and that sort of thing that was relaxed right away was just too much.
So, what is your take on the current status of getting a vaccine for COVID-19? There's a lot of trials underway. It's my understanding they're kind of rushing it and pushing through some protocols that you might otherwise use in a vaccine trial. I don't know if that's yielded any results, but I wanted to get your take on where that stands.
Yeah, so we at Emory, there are many, many vaccine candidates in the pipeline right now. We at Emory are about to launch in the next couple of weeks a phase 3 vaccine efficacy trial. So phase 3 efficacy trials are enormous trials where we try to see whether the vaccine works or not. Yes, this has happened at what we say is warp speed, faster than any vaccine has ever been developed in the history of infectious diseases. That doesn't mean that it's not safe, and that doesn't mean that corners have been cut, because that's not the case. What's actually happened, though, is just, rapid kind of scientific collaboration and support and government support behind development of these vaccine candidates. And so we are really excited to be launching this first efficacy trial at Emory in the next couple of weeks of a vaccine candidate. After that, there will be some that follow. There are, I think, at least 4 or 5 that I'm aware of. There might be more that are headed towards efficacy trials in the US, and then even more than that internationally. So this is something that we've never seen before. But again, I want to reiterate, it's happened fast, but it hasn't happened by cutting corners. So we do have good safety data on these vaccines. These vaccines have all gone through the regular process of determining their safety in earlier phase trials before they have entered efficacy trials. The difference of how that's been done this time around is the efficacy trial was basically planned at the same time as the safety trial so that it can launch the minute we have the safety data from the early phase trials. And that's not typically how things are done. It's a much more kind of linear process. And this time, everything's been done in parallel to make it faster.
So let's talk.
Dr. Kelly,
I'm sorry. Go ahead.
If I could ask a quick question about that, because I know that the phase 2 trials, which are generally around the safety, right, which have been
phase
done.
1 and 2, yep.
And the phase 2 trials it's not like it's 10 people. It's a fair bit of people, that go through. My understanding is even in some of the safety trials, the data came back with fairly robust immune responses and antibody responses that it's not sufficient to call it efficacious, like it's not sufficient to prove efficacy, but it is supportive of the hypothesis that it's at least showing the right response to achieve efficacy in a larger trial.
Yeah, you're absolutely right. You said it perfectly. So the phase 1 and phase 2 data that have been published to date, and a lot of it's not been published yet out there in the medical literature. It's just, scientists are talking about it and releasing their data early before it's published to understand, show excellent immune responses for many of these vaccine candidates. But we don't know that immune response means that you're protected. So if you think about, pre-COVID, my world was HIV prevention and HIV vaccine work. And so we can create an immune response to HIV with a vaccine. What we can't create is a protective immune response with a vaccine. And so the hope, COVID's different, coronaviruses are different, and there's no reason to think that we will be in the same boat as we have been with HIV, but the immune response data looks very good and very promising. You're absolutely right.
And so it's also my understanding that in order to actually get sufficient efficacy data, you have to test it in places where there is actually fairly uncontrolled outbreaks, right, with a fairly sizable population. Do you know where, for example, your phase 3 trial is going to be done, and how many people?
Yeah, absolutely. So the way that we determine efficacy for an infectious disease vaccine is placebo controlled. So what that means is that half the people are going to get the real vaccine and half the people are going to get the fake. We won't know who gets what. That's something called a blinded placebo controlled trial. So half the people get the real thing and half the people get the fake. And then we follow them to see who gets COVID. And at the end of the study, and at times there's also interim analyses, but that's a little bit confusing. But at certain points throughout the study, the analysts will look at the data and they'll say which group got more COVID between the two groups, the ones that got the real vaccine or the one that got the fake. And if there's less COVID and significantly, by statistics, significantly less COVID in the group of people that got the real vaccine, then that's an efficacious vaccine. And so that's how we're doing it. So this study is massive. It's being done at approximately 90 sites throughout the US. Just in the Atlanta area, broader metro area, there's 4 sites doing this particular vaccine study. The product we're doing is the Moderna mRNA vaccine. And so 3 of those sites are affiliated Emory, one's here at Grady, one's in Decatur at Emory Hope Clinic, which is behind Emory Decatur Hospital, the old DeKalb Medical. I also work over there as well. And then one's going to be on Emory main campus. There's another site not affiliated with Emory that's also doing this vaccine. I will say there's another vaccine that's entering trials very, very soon from a company called AstraZeneca. That vaccine is not being conducted at sites in Emory, but it is being conducted at sites around the city as well that are not academic affiliated. So a lot of options for people if they're interested in participating in research trials or in vaccine trials right here in Atlanta.
So if you're just joining us, everyone, we are talking to Dr. Colleen Kelley, who's an infectious diseases doctor and researcher. If you want to ask a question, we've got a few questions already. We'll get to them. Just create a Twitch account, sign up, give us a follow. Dr. Kelley, let's talk a little bit about your background for a bit. How did you come to be in the position that you are in? What got you into the medical field and to the field that you're in?
Sorry, the helicopter's landing, and I don't think my
Oh wow!
headphones are
Yeah,
working.
just so everybody knows, Dr. Kelley is broadcasting to us from Grady, where I understand that they are at capacity right now. Things are not good over there, so we really appreciate her taking time out of her day to talk to us about what's going on. But I just want to talk a little bit about who you are and your background, so our readers can know a little bit about where you're coming from.
Yeah, so you said I'm an infectious diseases specialist. I work for Emory University, but clinically I practice at Grady. Pre-COVID, I'm an HIV specialist, so I treat folks with HIV, and I also built my career on doing HIV prevention research. So around HIV vaccines, as well as pre-exposure prophylaxis and the immunology around HIV and HIV prevention. So I've been doing that for many years. And as what happened to most of us when COVID hit, we ran into the fire to help because that's what we do. We do infectious diseases, and this is clearly an infectious disease. So I've spent the last 4 or 5 months at Grady conducting clinical trials for treatment. So we participated in the remdesivir clinical trial that resulted in good results showing that patients treated with remdesivir did better than folks that did not get remdesivir. We are participating in other industry clinical trials here at Grady, and then about to launch these vaccine and other prevention trials. Something that's really interesting that's also coming is something called a monoclonal antibody. So part of our immune response to infections are antibodies. And when you get a vaccine, in most cases, what that's doing is making your body produce antibodies to the germ or the infection. Scientists can actually make those antibodies in the laboratory and make large volumes of those antibodies and then infuse them or inject them into people. It's something similar, we would say, like passive immunization. Instead of getting a vaccine, we give you the antibodies directly. So there's studies of that are coming in COVID for people that may have been a close contact of someone that had COVID, giving them an antibody to see if their progression to disease is prevented by giving them an antibody. So that's something else that's very exciting that's coming along. So that's a little bit about my background. Someday, hopefully, I'll get back to doing my passion, which is HIV and HIV prevention. But for now, this is where I'm needed.
Well, we appreciate, I think I can speak for everyone here, and we appreciate your service and your commitment and your willingness to drop what you were doing to come and help. We really do. I want to get to a reader question real quick, and then I want to let Crystal ask a few questions. Reader Kate Tobin asks, are there multiple strains of the virus circulating in Georgia?
I wouldn't say that there are multiple strains. I mean, in general, from a genetic perspective, there are differences in viruses, and different viral particles may be somewhat genetically distinct from each other. But when we think about different strains, we think about different types viruses that behave differently. And we don't have very much evidence of that we have certain viruses that are behaving differently than other viruses. So I would say in general, no, we don't have different strains.
And I think the core of that question is whether, if you've developed a vaccine for the virus that you're studying right now, is that vaccine, to the best of our knowledge, going to be effective to anyone that has it? And I think that the answer is yes, right? Because there is.
We think so, yes. And actually, going back to my roots again with HIV, that's the problem with HIV vaccines, is that, the different strains, which is, not really the right technical word, but in essence, the different strains, the vaccine can't protect against all the different strains. We don't have that same issue with coronavirus. Yeah.
Thanks, everyone, for your questions. If you want to ask one, create a Twitch account, sign up. Crystal.
Yes.
I haven't heard from you yet.
Okay, Dr. Kelley, I'm very interested in knowing, thank you for all that you are actually doing. I have family members in healthcare as well, so I know, and they're not doctors, but I know how stressful it has to be for you all right now, how much pressure you guys are under to, kind of help save the world right now. So I just definitely wanted to say thank you first. But my question goes back to the trials, and I'm just very curious because I know you said that you're basically going to inject the vaccine, and I'm guessing roughly, half is going to receive a vaccine, and the other half is going to receive a placebo. Um, but my question is, so what are they to do? How would they be? Would they all be exposed to COVID? So that it can be properly tested, or would they just go back in the world as normal? Like, I'm just kind of trying to understand more about like how it would work to actually see if the vaccine will work.
Yeah, absolutely. So, no, we're not going to expose anyone to COVID right now. Actually, people are talking about that potentially in the future, but that's not what will happen here. What we do is we put people into follow-up, or we say longitudinal follow-up. So yes, they go back about their daily lives. They take all the precautions. We tell them how to take precautions. We teach them about that. But unfortunately, some folks will still be exposed to COVID and still acquire COVID. And so we'll follow those folks for up to 2 years. We'll check in with them, on a monthly basis. We'll let them know to call us right away if they develop any symptoms. And then every few months or so, we'll bring them back in and test their blood for antibodies to see if they acquired COVID after they were vaccinated. And those, whether someone acquired the antibodies or whether someone acquired symptomatic disease after the vaccine is what we're looking for. So it can take a while. It can take time. To figure this out. So we have to wait for enough people to acquire COVID to be able to compare those two groups statistically to say whether the vaccine works or not. And that will take a little bit of time. That's also why this study is so massive. They're enrolling 30,000 people in the hopes that we can go faster. We can get the numbers that we need quicker.
Hidden in that answer, what's a little terrifying, and I think folks should know this, right, is that that's saying that of any population group of 15,000 people, because half are going to get the vaccine, half aren't, it is an absolute certainty that a significant number of those people are going to get exposed and develop, enough of a response to be able to validate this vaccine. Right? I mean, that's the unfortunate truth of what you're saying, is that we just happen to know that this outbreak is uncontrolled enough that any group of this number of people are going to be exposed to it.
That's right. You could not do this study in New Zealand, where they basically eradicated the virus. You could not do this study. They will not be able to develop a vaccine in New Zealand. It's not a good thing that we can develop a vaccine and we can do it quickly here. That's not a good thing. But we should be able to do it. It should be feasible for us to do it, particularly in the Southeast and places like Texas and California, where things are just, out of control.
Go ahead.
I was just going to say, to follow up to that, because when I have conversations with some people, the first thing they say is, at this point, they're waiting on the vaccine to save them. From what you just said, I don't see that happening within the next 6 to 8 months. So what is your viewpoint on that?
I think it will be a miracle if it's in 6 months, but I think we're looking more like 8 to 12.
Right. Okay.
But maybe if it's a highly, highly effective vaccine, maybe 6 months, but and then we have to vaccinate 300 million people, 300 plus million people in the US, never mind the globe, in order to protect everyone. So I think you're right. I think we're looking at next, hopefully by next summer.
Wow. Okay.
Which is a year from now.
So if you're just joining us, we are talking to Dr. Colleen Kelley, who is an infectious diseases doctor and researcher with Emory University. She joins us today from her office at Grady Hospital. If you want to ask Dr. Kelley a question, please create a Twitch profile, give us a follow, and put your question in the chat. We want to hear from you. Dr. Kelley, one of the things that we're hotly debating right now, and I'm actually going to be talking to the DeKalb County school superintendent tomorrow, is whether we can have school. DeKalb County, a lot of metro school districts have said, we're not going to do any in school. We're going to go to all virtual learning. Some districts are still on the fence. Some are doing a half and half. In your opinion, is it even possible to have in-person school right now? based on where we're at?
Yeah, so I have 3 school-age kids of my own. So I completely understand the trauma that we're all undergoing and our kids are as well. School cannot look anything like what we're used to. I think there are ways that we could do some in-person instruction safely, but it has to be, the typical kind of school day would have to be completely stood on its head. So it would take massive innovation. It would take tremendous commitment and a lot of resources. I don't think that we are appropriately resourced to be able to do that. So I also think we need to get in a little bit better place with control and declines in infections before we consider that. I'm not sure how closely folks have been looking at the Georgia numbers, but the last 3 or 4 days, we seem to have been, in a slight decline, especially in Fulton and DeKalb counties. If that could continue for the next couple of weeks, and we were able to kind of innovate how to do, small group classrooms, outdoors, limited amounts of face-to-face contact and time, and think about all of those things, it is possible. But it's going to take just a tremendous amount of, like I said, innovation, commitment, resources that I'm not sure that we have.
Yeah, we're not traditionally good at providing those things to our school systems in any
That's
case.
right. That's
right.
It can't look anything like it looks
Right.
like what we think of as normal school.
I mean, we make teachers pay for their art supplies right now. We make teachers pay for half their supplies in the classroom.
Right.
We can't be in an environment where we're requiring them to buy their Clorox wipes to keep them
right. Right. PPE, personal protective equipment, tents to have outdoor classrooms, ways that, to work around having, not having to put kids on buses and things like that, thinking about feeding kids, but, not necessarily in the school environment, all of those things have to be considered and factored in. And I just don't see that happening in the immediate future, as much as I want it more than anything, and just as much as everyone else.
So we have a question from Tiff-Tomatic, that's the screen name, and they ask, for those of us who have parents who are at risk and are more older than 60 who are not taking this very seriously, do you have any sage advice about how we can talk to them and help them understand?
Yeah, I'm not sure if I have any sage advice. I think it's hard for folks that aren't taking things seriously. I think part of, and particularly in medicine, we talk a lot about meeting people where they are, as opposed to trying to kind of push them all the way over the edge and changing their opinions, and maybe finding what it is that they're objecting to so much, and kind of trying to move the needle just a little bit, kind of gradually, with respect to, is it the mask wearing that they object to? Is it not believing that things are real, which there are people out there that don't believe that our hospitals are full, and I'm not sure how to convince them other than to give them a tour. Kind of figuring out what are the things that they're objecting to, and figure out which one of those things you could potentially have the opportunity to move the needle just a little bit and gradually.
See, it's been my experience that older people are more likely to take it seriously than not, at least the people I know, and I know some deeply conservative older people who are scared as hell about this and are taking it seriously. I note just for the record that, Trump has lost support in Florida, and a lot of that has come at the expense of older voters who are likely conservative voters, and the theory being that, they feel that they aren't safe because of some of the things that they've seen. So I'm sorry that there are people who have older relatives who aren't taking it seriously. I feel fortunate, though, in that a lot of the older people that I know are definitely they enjoy living, so they're gonna take it very, very seriously. Getting back to the schools question for a second, one thing I hear a lot about is what age groups spread it the most or are better at spreading it. and there seems to be some common belief that it's more likely to spread the older you get with the kids. Talk to us about that. What can you tell us about that? Because when I hear that, I'm like, okay, my son's kindergarten age. Why can't he go to kindergarten if he's not a super spreader?
Yeah, I think the shorter answer is we don't know yet. And to me, I find it exceptionally frustrating that we don't know that yet. We should know this by now, but we don't. I think you're right. I think from the data that we have so far, and there's a very, very large Korean study that just came out in the last couple of days around kids, would suggest that yes, the teenagers and the middle school kids are more likely to transmit than the youngest of the young. So the preschool, the pre-K, maybe even as much as kindergarten. I would say that is, based on the data we have so far, that looks to be the most likely scenario. And so, yeah, I think if we, for a lot of reasons, if we did go back to in-person school, that's where it should start. And, that's where it should be prioritized, not just because of disease, but because kindergartners can't sit in front of Zoom for more than 30 seconds. For a lot of reasons, it should start with the youngest of the young and work its way up.
Hans?
If I could, I wanted to go just very quickly. I think there's been, this is switching back to the older folks that have trouble sometimes with the information or not following the recommendations. I do think that we have a tendency to default to a conservative liberal divide when talking about this. And I don't necessarily think that holds up on this particular issue. I think that we have more of a conspiratorial mindset versus non-conspiratorial mindset. I mean, and so I want to point out, Marin County, California is probably the most liberal county in the United States of America. And it's also the epicenter of the anti-vaxxer movement, right? And so this is, if we're to provide some answers to the listener that wants to know how to engage with folks like that, there are pretty good resources out there for how to engage on anti-conspiratorial mindsets and how to, none of it's easy, but do the research on, it's not necessarily helpful to look at a conservative liberal divide. It's more helpful to what are the things that makes people susceptible to conspiracy theories and try to engage on some of that, because that's, I think, where we're seeing a lot of the issue here. People worried about vaccines. People think, the mask stops me of my ability to absorb oxygen. I mean, then why do doctors wear them? So there are things that are out there that might help, and good luck. That's a tough row to hoe, I would say.
Yeah.
The problem with conspiracy theories is, by their natures, any conflicting evidence is interpreted as you're part of the conspiracy. They're self-reinforcing in a way that makes it hard to. And I think the other problem too is you can't see COVID. You can only see the patients. And if in your experience you don't know anybody who has had it, or you haven't seen somebody who's really sick with it, it creates this sort of magic thinking of, well, it's not happening to me, so therefore it's not happening. And we just have a huge problem in this, and it's not just with public health, but it's with a lot of things, and just the inability to build consensus around these things that are important to us. Crystal, we haven't heard from you in a minute. What's on your mind? You're muted.
I had to unmute myself. So I'm sorry that we keep bombarding you with questions and flipping back and forth. But I think what has been so amazing to me is that usually kids are the ones who actually are the super spreaders. And now with this particular virus, you're saying that the adults are the super spreaders. So I don't know if there's anything scientifically that you have seen that kind of could explain that more, because I do understand that you guys are kind of, still, sifting through a lot of all of this, but could you lend some, some thoughts on that, on why that's happening?
Yeah, I would say though, like, coming back to it, we still don't know that that's the case, that children are not, super spreaders. I mean, I think there's a lot of anecdotal evidence to suggest that they're not. There's, data from research studies to suggest that they're not. Children definitely are affected. Children definitely can be infected and can pass it on to other folks. But whether, when you think about, the little kids that go to, school every year, it's just the petri dish around Christmas and everyone gets sick from their kids, going to daycare, going to schools. It's not clear that that's the case here. It's definitely the case that adults have the severe disease. That is absolutely the case. Kids that get this, it's extremely rare for kids to have a severe outcome. Doesn't mean it doesn't happen. It can happen, but it is rare.
Well, so here's my question behind that. It's one of the things that I've been hearing different governors say things like this, that kids are not affected. But are we not really seeing children be affected because schools closed, advantageously, which was great. But is that really can we really say that as like a true statement? If that makes any sense for me to ask it in that way.
No, I think you're right. I think we wouldn't know the full impact without schools being open. That said, I will tell you, in March, we had rampant, and February, likely end of February, beginning of March, we had rampant, widespread, spread of COVID here in Atlanta that we had no idea about. And so that's one of the anecdotal things I kind of go back to and say that, we didn't have anecdotally, teachers and school staff members falling ill by the dozens back in March. That just, wasn't happening. And that's anecdotal evidence. Absolutely. I don't have any kind of scientific data to back that up. But, that's another reason to suggest it was circulating widely in our community, but it doesn't seem like it was in our schools back in early March before the shutdown.
I do wonder if I could ask, or this isn't really ask, but put forward. I think that there is generally a level of misunderstanding on how science works sometimes, and
right.
this when you're saying anecdotally here, we had this, but we don't know for sure. I think people are going to genuinely ask, why don't you know for sure? And I think it's important to point out that ethically, you can't go infect a bunch of schools to find out if kids have it. You can't just send kids back to school and let's see what happened. Like, you're very limited in what you can do to actually create a study to find out whether or not kids would be big spreaders, right? And so it's not a matter of science not working. We could, so let me say this: if nobody cared how many people we killed, we could answer the question in a couple of weeks whether kids were super spreaders, right? But we can't do that.
Yeah. And back in March and February and even now, we still don't have enough testing to appropriately do, we call it surveillance, to appropriately test people serially who might be at risk. So like in a school setting, if I had a dream come true, we would test everybody going to school and all the staff on some regular basis. I mean, we would need an epidemiologist to tell us what the right frequency is, but test period, just like they're doing with all the sports teams now. And then, that those teams are getting tested serially at some interval. I'm not sure what it is. And then if someone tests positive, they pull them out immediately and they isolate them and they send them home. If we could do something like that in our schools, that would be great.
So
but that's interesting. Oh, go ahead. If you have, I would rather do Twitch.
Yeah, we've got some great questions coming in, so I want to make sure we get to them. So Kate Tubin asks, the Washington Post ran a very interesting article recently asking infectious disease experts about what they do and don't do. How about you? Do you get takeout? Do you eat outside at a restaurant? Inside? Do you go to the hair salon, the dentist? Do you fly on an airplane?
Yes, I saw that quiz and took it myself. So I do a lot of those things. I do not personally go to restaurants. I have not flown on an airplane, but I am thinking about it because my brother had a baby and I want more than anything to go see that baby. What were some of the other things? Hair salon. I have not gone to a traditional hair salon. I can't remember what those other things are. Takeout. Oh, I've been doing takeout the whole time. There's no way we could survive in my family without takeout. We did not. I am not. So that takeout and those kinds of things that we're worried about, kind of hard surfaces, or we say fomite transmission, that does not concern me. If you if you're getting takeout or groceries or what have you, and you're frequently washing your hands and you're not touching your face and your eyes after you touch, something else that someone's touch, those things don't concern me tremendously. So yes, I've been doing that the whole time.
So Alex Brown, who is our intern for the summer, asks, how do you think this pandemic compares to the HIV/AIDS pandemic? Epidemic.
Yeah, so there are some very stark similarities, a lot of differences. Obviously, this is a respiratory virus, not a sexually transmitted virus, but the fact that we see the same kind of marginalized and discriminated against populations that are affected by HIV now be the same folks that are most hardly hit by COVID, and by that I mean Black and Latinx populations, is just really, really heartbreaking. And so that is the one similarity. As far as elderly people are more severely affected by COVID rather than younger folks, that's something that's very different. So there are a lot of similarities and a lot of differences. I would say, my training and my experience in infectious diseases in general and HIV is easily transferable to this.
So that's a good segue into a question I had. I read an interesting article in the BBC about T cells, and I know enough about this to be really dangerous, so I wanted to let you speak to that. But the gist of it was that there might be people with a hidden immunity to it because they've had certain colds and other types of viruses in the past that have produced a sufficient number of T cells that might ward off. So in other words, in the asymptomatic cases, there's enough of these T cells around to successfully fend off the virus, and then in some cases there aren't. And that's my layman's understanding of it. You probably have a better understanding of it than I do. But have you seen that article, and what are your thoughts on it?
I haven't read it. I saw it on Twitter today and need to go back to it. But basically, there's two arms to the immune system, in basic terms. One is the arm of the immune system that makes antibodies, which are the things that if a virus or a germ infects you, the antibody immediately binds up and makes that virus or that germ, bacteria, not able to infect you. The other arm of the immune system is, in general, T cells. Again, these are very basic terms. The T cells help the part of the immune system that makes the antibodies. The T cells are also responsible for killing cells that become infected that the antibody couldn't protect from. So both are likely important in immune responses. Whether that's going to be the mechanism why some people are protected or don't get as much severe disease, I doubt it. But it is possible. What that's just saying is that people likely have a subclinical immune response that is detectable in their T cells, but not necessarily detectable in their antibody response. And people have theorized, there's a lot of different coronaviruses out there. Most of them just cause the common cold. For whatever reason, this one is significantly more devastating, like SARS and MERS were as well. But the common coronavirus that causes colds, people get those all the time. And there's some curiosity around people that have had exposure to those coronaviruses in the past, whether that somehow is helping them. But we don't know that yet.
I wondered, too, when I read that, if that might explain why there is less prevalence among children, because they are exposed generally when they're around other children. They're exposed to more things like colds and things that would provoke these responses. That was just something that I thought about while I read it. I don't know if that's a leap or not, but it
I
was
don't
interesting.
think so, because generally, as you know, your immune system has memory, and so it remembers what it's seen in the past. And so as you age, you get more and more immunologic memory, and so kids generally have less than an adult. Um, so
I think what's interesting. So I had COVID, very low symptom COVID, and
I'm glad.
my ABS tests came back negative.
Antibody.
Yeah, the antibody test came back negative,
Mhm.
which of course, you know, they're pretty high false positives and false negatives, I guess. But the T cell response is, I think, part of the hypothesis behind the T cell thesis is trying to explain why, you know, you have these definitive cases of people that had it, and yet within weeks after they clear it, there's no there's no discoverable antibodies within their system. But
And that's something that we're seeing a lot of in people who either are asymptomatic and test positive or who have very mild disease. A lot of those folks are not developing antibodies. One thing I saw recently, though, is it may just be taking more time. And so that those folks may develop antibodies later on, maybe a few weeks or months later. That's unusual, but that is
so you're
something that's
saying
been
I have to go
suggested.
get my blood drawn again?
Potentially,
Yeah.
potentially, yeah.
What is interesting, and this is relatively serious, right? I did have very, very low symptoms, just like a couple days of cough, no fever, that. But I have a persistent and low grade cough. Has not gone away, and it's the same kind of pressured cough that I had when I had it. And so I haven't gone and got an X-ray or anything like that to check it out. But I have been reading about people that have symptoms for well, I mean, we don't know how long now, right? Because we're still kind of in the early phases of this disease. But months after they clear it, they can still show some symptoms.
Yeah, I mean, in my experience, those have been the people that have been really sick. So time will tell, but I think you're right. I think we don't know how this virus can certainly linger for a long time. So it's certainly possible that we'll know more about the long-term effects.
So if you're just joining us, this is the Decaturish Twitch show. We are talking to Dr. Colleen Kelley, who is an infectious disease researcher at Emory University. If you have a question, please create a Twitch account, give us a follow, jump in the chat and ask a question. We're going to be on for about 20 more minutes, so go ahead and get those questions in if you want them answered. Crystal, let's hear some more from you. What other questions do you have?
I feel like I'm jumping around.
That's
I was
okay.
literally just thinking about, I apologize, Dr. Kelley. I was just thinking about going back all the way back to the trial, the vaccine studies. I'm sorry to go back that far.
No,
but
that's great. That's what I'm spending all of my time on.
One of the questions that I thought about was the people that are in the trials, have they already had COVID or not? How will that work?
We're looking for people that have not, to their knowledge, had COVID. You're right. Some of the people that we enroll will likely have had it and not known it. But the fact that we're enrolling, 30,000 people, that shouldn't be a large proportion. So we're looking for folks that have not had COVID to their knowledge.
Okay. And another follow-up question. So basically, from my understanding, there are a lot of hospitals that are near capacity, at capacity. Well, I don't know. I can't say, but I know you said you guys are pretty full. We're still going on business as usual here in Georgia. So what's going to happen if we continue the way we are?
Yeah. this is how it's going to be for the foreseeable future, I guess. You know, I'm a little bit hopeful seeing, like I said a few minutes ago, seeing kind of the curves flatten a little bit, maybe even decline a little bit in Fulton, DeKalb County. I'm hopeful that that's, you know, the mask wearing that's become more widespread and mandated, but not mandated. So, you know, I'm hopeful that we'll see some declines with good mask wearing. Are we going to get back to, you know, in June, like mid-June? I was really hopeful, you know, where our hospitals were really emptying out. We were not seeing very many folks at all. So are we going to get back to that level? I don't think so without, you know, strict social distancing. I'm not sure that we should. That was really hard. And if we're going to have to maintain this for the long term, we need to do something that's sustainable. And I know that certainly wasn't sustainable, that, you know, the hard extreme shutdown. So I'm not sure that this isn't going away anytime soon, but we need to get to a less widespread transmission within our community in order to feel safe.
So we got some good reader questions rolling in. We'll get to them. Question: what would you advise for a relatively healthy adult about going in to see a doctor for routine preventative tests and procedures like mammograms and going to the dentist? Should we just wait?
I mean, I think that you can go to the doctor if you need to go to the doctor. A lot's being done now over telehealth, but of course you can't get a mammogram over telehealth, and you can't get your teeth cleaned over telehealth. So no, I'm starting to do those things myself with my family. We made dentist appointments coming up soon. You know, we can't, you know, completely abandon all of those things. There are preventive measures in place with protective PPE. You know, healthcare providers are protected. I can't tell you how many hundreds of patients or more with COVID that I've personally seen. And, you know, with PPE, I am protected. And your dentist is protected if your dentist wears appropriate PPE. So, I mean, I think those things we should be able to get back to doing safely. Going out to indoor dining, going out to bars, that sort of thing, movie theaters, that I don't think we can get back to anytime soon.
Alex asks, what would there potentially be a hierarchy for how the vaccine would be distributed, like to medical workers and vulnerable populations first?
I think that there is definitely potential for that, for those at highest risk of severe outcomes being eligible to receive the vaccine first. But I don't think that's been, you know, planned as of yet, but I think there is potential for that.
Well, we're really good at planning, so I have a lot of faith that we're gonna roll that out. One more question from a reader: what is a good web source for objective and accurate information about COVID-19, the number of cases, the causes, etc.? I know people who have discounted CDC and the Georgia Department of Health sites because of the admitted mistakes.
Yeah, so what's difficult about the Georgia Department of Public Health site is the way that they are back calculating their dates. It doesn't make any sense to me. So the AJC actually has a COVID dashboard where they don't back calculate the dates, and they tell you exactly how many folks tested positive on a certain day, as well as the number of hospitalizations on a certain day. And I think that using a combination of those things, the Georgia DPH plus the AJC data, and, you know, understanding why the curves look differently, and AJC does a very good job of explaining why they look different. Those are pretty good, and I do use both of those sites, but knowing that Georgia DPH is doing some weird stuff with their numbers. Yeah, CDC numbers, I think they're probably hopeless at this point. You know, CDC is good for general information about protecting yourself, about, you know, healthcare settings, how to protect healthcare workers and that sort of thing. But it's such a mess right now.
Yep. I want to wade in a little bit. I'm a little bit of a data head myself. And what has frustrated me a little bit about the Georgia website is, you know, you can find innocuous explanations, even though it's still a little cross-eyed, for why they back calculate weirdly, right? I mean, they may say we're trying to make it more precise, we're trying to have a bigger picture. But recently, I don't know if you've seen this, but recently they showed a heat map by county of Georgia. And they showed it, this is what it looked like 2 weeks ago. This is a heat map. And they would color the counties by the prevalence of infection.
They're just changing the colors.
Correct. Well, and on this case, too, what they did is they changed the baseline for what constituted an emergency, right? And so the two maps, when you set them next to each other, look exactly the same because it's the same counties that are red and it's only a couple of them and it's not that much. But they dramatically altered the baseline. And so Georgia actually has 50% more cases than it did between those two, but the maps look the same. It's really hard for me to see an innocent explanation for data manipulation. It's not data manipulate. They're not manipulating the data. They're manipulating the baseline, the communication of the data. Yeah. Right? Like they're manipulating the message behind the data. And that just, I find that infuriating. You don't have to side with me on this against the GPA.
No, I don't look at the maps on that website. I just look at the curves. Yeah. Look at the raw numbers on there. The maps, I agree with you. They just, it's always Fulton, DeKalb, and Gwinnett that are bright red on that top map on that website, and it's been that way all the time. And the red, what classifies you as red, the threshold just keeps going up. Yeah. Yep.
The other thing that I meant to ask this a little bit earlier, but there is I personally feel there's been a bit of a breakdown in the way that we communicate in this crisis, right? And it started, I think, a little bit in the beginning. I understand when the CDC and the NIH were recommending not using masks, largely because they were, I think, trying to preserve limited stockpiles for emergency workers. But the communication around that got interpreted, and I don't blame the people for interpreting it this way. I kind of blame the communicators. Got interpreted that masks don't matter and masks don't work and masks don't help. And once that message is out there, clawing that back, right? That's part of the reason why we're having as much trouble as we're having right now. I think that of the lessons we learned from our response to COVID, a huge one needs to be around how we communicate in the very earliest days, because undoing that, it's almost impossible.
Yeah, you're absolutely right. We did a horrible disservice to our pandemic response over masks. I personally have been a mask believer since day one. I've had my family and friends wearing masks long before, because I couldn't believe how we were, as you said, communicating the utility of masks to folks and, really saying that they didn't need them, which I didn't think that, Asian countries have used masks for decades. and that's what we used in the 1918 pandemic as well. And to discount those countries, especially that were having highly effective responses, and that was one of the tools that they routinely use, and to say that it doesn't work was really, really stupid, in my opinion. Yep. And to say that they don't protect the wearer at all, I think is false. I don't think that's true at all. And so I think, yes, if we're all wearing masks and everyone's protected, and if only one person's wearing a mask, it's not giving them a lot of protection, but it's giving them some protection. Mm-hmm. So I agree with you. I think that has probably been one of the biggest fails of the many fails of our pandemic response, but that's one of the big ones.
So we're approaching the hour, and I do want to be respectful of Dr. Kelley's time because I know she's got a lot going on. I did want to ask, as a forward-looking thing, is a lot of people are feeling kind of hopeless right now. I know I've struggled with that, especially as we've gotten these responses about schools and virtual learning. Is there any reason to be hopeful or optimistic right now about what's coming down the road, or are we in for a long slog?
We're in for a long slog, but there's absolutely reason to be hopeful. And I do think that one and likely several of these vaccine candidates will be efficacious, and that will kind of bring us out on the other side of this. I just don't think it's going to be as quick as we'd all like it to be. Like I said, I almost certainly, I think by next summer, but I think, spring, summer is what we're likely looking at for, widespread vaccine availability. I think the schools was a big punch in the gut to all of us. Because I don't think anyone ever imagined that would happen. But it did. So I think, I do still have hope that the kids will go back to school. But like I said in the beginning, it can't look anything like our normal school activities. But I do hope that they can go back to some level of in-person learning.
Let me ask, if I could ask really quickly,
Sure.
the test that you're doing, the messenger RNA vaccine, is that the Pfizer? It is not. Okay.
Pfizer does have an mRNA messenger RNA vaccine, but that's not this one. This one is from a company called Moderna. But the Pfizer one is also close to entering efficacy trials as well, is my understanding. But that's not here.
The reason why I was asking, or this of course remains to be seen, but the CEO of Pfizer has claimed that they're already ramping up production for it. Like they're actually going heavily. They're just going to go ahead and produce 100 million doses pre even the efficacy trial, on the hopes that if it is effective, then they'd be immediately able to deploy it. Obviously, that's an enormous risk on their part, but if you do get good efficacy data back, how much time do you think that potentially takes out of the response?
Yeah, so that's one of the things when I talked about we're doing things in parallel now instead of typical in series, and that many of these vaccines, with the support of BARDA, which is it's a government agency, biodefense, BARDA, anyways, is supporting mass production of these vaccines before we even have efficacy data. So that's what we're doing. We're doing everything in parallel. The phase 1s were being done at the same time we're planning for the phase 3, at the same time the vaccine's already being mass produced. And the nice thing, what will be wonderful about these mRNA vaccines, if they work, is they're very easy to mass produce. You can make many, many, many doses very quickly, which is different than other vaccines. So if these mRNA vaccines work, it's going to be huge. It's going to be huge.
Dr. Kelley, what are some public policy decisions that our leaders can make right now to start to put a dent in what we're seeing? What, in your opinion, can be done right now?
Mask mandate. I think we've, in our area, we probably need to close again indoor dining, bars, movie theaters, any place with indoor activities, at least for, some period of time. I'm not sure exactly what that is. I would, again, leave that up to the epidemiologic modelers. But I think that those are two things that we can do pretty easily. Well, easier said than done in Georgia.
You mentioned innovation, or you mentioned that, we can't have like a full shutdown like we did before because it was kind of hard on everyone. What are some creative, innovative outdoor things people could still be doing, even that those indoor dining places or gyms or other things may be shut down? What are some of your thoughts on that?
Yeah, I mean, I think in the hard shutdown, like back in March, people weren't even talking to their neighbors out in the street because everyone was oh no, we're quarantining. Outdoor activities are, as long as you're not, face to face with someone, outdoor activities are generally significantly safer, especially in the summer with the sun. I mean, sun inactivates the virus like extremely quickly. So I think if you're outdoors and you can socially distance, that's a pretty safe activity. And so we, need to continue to encourage that and support that because people need that and they need that kind of social interaction. I think you can safely go to the doctor. I think you can safely, get your hair cut. If you're in a place where you're wearing a mask and your hairstylist is wearing a mask and there's not a bunch of other people around, that's relatively safe. So I think that there are things that we can do. And so we need to detail those for folks and tell them how to do the things that they want and need to do, how to do them safely.
Dr. I'm sorry. We're going to wrap up in a little bit, but I wanted to really quickly before we go ask you what models are you following that you've found to be the most, I wouldn't say reliable, but the least susceptible to these fluctuations that we see in a lot of these models. What are you following, and do you have any parting thoughts for us before we wrap it up?
Yeah, I think all of the models are so models are based on assumptions, right? And we have to make a lot of assumptions right now in order to create these models. They've all been somewhat all over the place. So there's a couple that I do look at periodically, and I'm probably going to forget what they are right now, but there's one, I think, from the University of Washington. I think it's ICME or ICHE.
Yeah.
There are a few that I think are reasonable. But I'm sorry, I'm not going to be able to pull them right out of, they're bookmarked in my computer and my phone and that sort of thing, and just Googling. But I think the models have been really difficult. And I think, it's because of how many assumptions we're having to make without data.
So the other thing about modeling, especially in this environment, is when you're dealing with exponential growth rates, part of what you're modeling projecting forward is the behavior people are going to have in the future. But the actual point of the model is to influence their behavior so they stop doing whatever it is now that's causing all of that problem. So it in some ways, it's the startling and terrifying information on the aggressive models that get people to say, oh shit, I'm going to wear a mask.
Yeah.
Thus invalidating the assumptions that went into the model, right? I mean, it's not, these things are not independent variables.
Right. No, I think that's true. If you get more behavior change than what you put into your model, then your model is going to, over predict the outcome, and vice versa. So,
Dr. Kelley, do you have any parting thoughts for us before we let you get back to work?
Parting thoughts. I think there's absolutely hope, and I think there's a lot of hope in vaccine development. I think it's going to take a little bit more time, and so we need to hang on a little bit longer. Wear your mask. Absolutely wear your mask. Wash your hands. Don't touch your face. And do what's reasonable for you and your family with respect to limiting your activities. As best you can. So I think wear your mask. Wash your hands.
Dr. Kelley, thank you so much for everything that you and other healthcare workers are doing for us right now. Thank you for taking time to talk to us and educate us a little bit about what's going on. And I hope as we get further along, we can invite you back and maybe get some updates about what's been happening. But definitely take care of yourself. I wish the best to you and your family. To everybody who's watching, thank you for watching. We're going to have a special edition of the Twitch show tomorrow at 10 a.m. with the new DeKalb County Superintendent. Maureen Downey with the AJC is also going to moderate that. It'll be a good show. Please tune in. And we will also have a show on Friday. We'll be announcing the details about that soon. I hope you all have a great evening, and we will see you tomorrow morning at 10 a.m. Have a good night, y'all.